today is Dr. Geoffrey Block to discuss the incidence and prevalence of hyperkalemia. Welcome, Dr. Block.
Thank you very much. I'm really pleased to be here.
Can you tell us a little bit about the incidence and prevalence of hyperkalemia?
Yeah, absolutely. Hyperkalemia, or elevated serum potassium, is a very prevalent problem, in particular in groups of patients with specific comorbidity, including chronic kidney disease, congestive heart failure, and diabetes. And so when you talk about the incidence and prevalence, it's slightly different depending on which of those populations you look at. Clearly, the highest risk group are those with chronic kidney disease. The kidney is the organ which is responsible for maintaining potassium homeostasis ultimately. And so clinical trials or observational trials that look at the incidence of hyperkalemia in patients with kidney disease show that as kidney function diminishes, the proportion of patients with hyperkalemia is probably moves from approximately 20-25% in patients with stage 3 all the way up to 45 to 50% of patients with chronic kidney disease stage 4. And that's in a single point in time. If you look serially over time, the majority of patients actually with chronic kidney disease, as they have entered stage 4 and certainly move towards stage 5, will have episodic hyperkalemia. Patients with congestive heart failure, the incidence rates and prevalence rates are quite different. Overall, they're lower, but can be as high again as upwards of 35 to 40%, depending on the criteria used to both define hyperkalemia and the criteria for that particular clinical trial with congestive heart failure. In the randomized clinical trials that have looked at the prevalence, or incidence of hyperkalemia within a randomized clinical trial of patients with heart failure is pretty low, on the order of 5%. But we know that when those trials are translated into clinical practice, in fact, the incidence of hyperkalemia is quite a bit higher than what's demonstrated in the trials. Often doubling what is seen in the clinical trials, simply as a result of the lack of exclusion criteria once you put those into the real community practice. So it's a very, very prevalent disease. I guess as a general rule, I would say in those at risk, and we can talk about that a little more, the overall prevalence is somewhere between 30 to 50% of patients will have episodic hyperkalemia.
So what are some of the comorbid conditions that contribute to hyperkalemia?
Yeah, the most important are the three that I mentioned, which are chronic kidney disease, diabetes, and congestive heart failure. So each of these plays a unique contributory role towards problems with potassium homeostasis. Chronic kidney disease is the most obvious to understand. The kidney, as I said, is the organ that is responsible for the finite regulation of potassium excretion, and when the kidney function is diminished and as a general rule with reduced nephron function, you see increasing prevalence of hyperkalemia. So anyone with chronic kidney disease, as they move from stage 3 to 4, stage 4, and then on to stage 5, will be at risk for hyperkalemia, and it's very common. The second group are those with congestive heart failure, and this is for several reasons. The first reason is due to the pathophysiology itself of congestive heart failure, which produces sort of a setup for patients being unable to get rid of potassium load. But more importantly is the widespread recognition of the use of medications in this population that contributes to hyperkalemia. And that's also true for the third group, which is diabetes. So patients with heart failure, patients with diabetes, and patients with kidney disease, it's recommended on the basis of very strong international and national guideline recommendations that they receive medicines that include agents that block the renin-angiotensin-aldosterone system. And any of those medicines, regardless of whether they are ACE inhibitors or angiotensin receptor blockers or mineralocorticoid receptor antagonists, will in fact predispose to hyperkalemia. And so we see a tremendous amount of hyperkalemia in those three groups. It's important to note, I should say, that while those are the three groups that are at most risk for hyperkalemia and in whom we see it occur most commonly, that's also the group who get the most benefit from those particular medications with regard to reduction of progression of kidney disease, reduction in cardiovascular events, and reduction in all-cause mortality. So the use of these medicines in those particular subgroups is something we think is absolutely important. However, we have to recognize that they are, in fact, very likely to develop hyperkalemia, and we have to both pay attention and potentially treat that.
Can you tell us a little bit about the pathophysiology of these conditions and the accompanying treatments that contribute to this increased risk of hyperkalemia?
Sure. So the basic concept is that cells within the distal part of the kidney collecting tubule, and known as principal cells, are the cells that are most responsible for the final potassium regulation. And the pathophysiology is such that anything that impairs urinary flow to that part of the kidney will impair the ability to get rid of potassium. And anything that impairs the production of aldosterone will, in fact, impair the ability to get rid of potassium as well. Aldosterone works in this particular cell type called the principal cell, and one of the things that it does is help reabsorb sodium. And as a consequence of the increased sodium reabsorption, that cell secretes potassium. So anything that stimulates that process will help get rid of potassium, and anything that inhibits that process will lead to a predisposition to hyperkalemia. And so all of the three medicines that I mentioned, or classes of medicines that I mentioned, have a direct effect on the ultimate production of aldosterone. So renin, angiotensin converting enzyme inhibitors, direct renin inhibitors, angiotensin receptor blockers, and of course mineralocorticoid receptor antagonists will all block the functional effect of aldosterone, which is one of the things that contributes to their benefit in reducing events and reducing progression of chronic kidney disease, but will invariably predispose to this problem because of the mechanism of action of the drugs towards hyperkalemia. When you add additional risk factors like congestive heart failure and reduced perfusion and renal blood flow and reduced distal sodium delivery to that part of the kidney on top of those medicines, then you clearly have this setup that is making it very difficult for the kidney to get rid of potassium. So the other thing is that patients with diabetes, and as people get older, and particular diabetics who get older and have progressive chronic kidney disease, they often have a condition that's known as hyporeninemic hypoaldosteronism, which is a consequence pretty unique to diabetic kidney disease, but because of its effect on this particular part of the kidney, will predispose those patients to hyperkalemia pretty clearly. And so we see it very, very commonly in diabetics. We see it very, very commonly in patients with heart failure given these medicines. And of course, we see it very commonly in patients with kidney disease for the same reasons. It's recommended that patients with kidney disease, particularly proteinuria kidney disease, get this class of medicines, some of these as first-line therapy. So there's really no surprise that the three comorbid conditions are all related, and they all predispose to high potassium. And as I said before, what's interesting and important is that while these medicines have risk, they have absolute benefit, and there's no question the benefit of these medicines outweigh the risk associated with hyperkalemia. And one of the things that you may be aware of, but is really quite important, is that we now know that the current treatment pattern when someone gets hyperkalemic, so either they have developed a single episode of mild or moderate hyperkalemia, the response to this by clinicians is almost always to reduce the dose of those medicines or even stop those medicines in those patients. And some really interesting data that has been released not very long ago has looked at this and really, both surprisingly and importantly, demonstrate that stopping the medicine or reducing the dose of these medicines, in fact, is not a good idea. It results in an increase in cardiovascular event rates and an increase in mortality, actually a staggering increase in mortality in patients who end up getting their medicines discontinued. In the aforementioned populations that I just described, patients who end up getting their medications discontinued because of hyperkalemia end up having nearly double the risk of mortality over time compared to those who are able to stay on those medicines. So really underlies the important point of understanding the risk of the medicines, but finding a way to keep people on them.
Hyperkalemia is usually asymptomatic, but it can be associated with muscle weakness, flaccid paralysis, and ECG changes. I'll ask that again. Hyperkalemia is usually asymptomatic, but it can be associated with muscle weakness, flaccid paralysis, and ECG changes. Can you tell us a little bit about these?
Sure, absolutely. The basic concept here is really quite simple, honestly. The potassium is a primarily intracellular cation and is fundamentally important in setting what we call the resting membrane potential of that cell. And the resting membrane potential is what helps determine how quickly that cell reacts and responds to an electrical and produces an electrical stimulus. So in the cardiac conduction system, the ratio of the amount of potassium outside the cell to the amount of potassium inside the cell is the major determinant of how quickly that cell will fire. And as a consequence, it's really important that we maintain the ratio of potassium inside and outside the cell. And when we don't, we can see really classic changes in the ECG. The changes start with mild hyperkalemia, and the first thing that we see is that in the precordial leads, you'll see the T wave start to get tall and peaked. As the hyperkalemia progresses and the ratio of the inside to outside becomes even more abnormal, you start to see a flattening of the P wave, which is related to the atrial conduction, and then you start to see the QRS itself start to get longer and longer and longer. And ultimately, when you start to see QRS widening on the ECG, you know that patient has severe hyperkalemia and they're near having a lethal event or potentially lethal event. Now, these changes on the ECG reflect changes in nerve conduction and muscle excitement. So it's not surprising that the clinical manifestations are related to neuromuscular symptoms like weakness and paralysis. Now, those are really late findings, and honestly, by the time you see those kinds of findings, you can be pretty confident the patient has severe hyperkalemia. And it's important to realize that these ECG findings, while if present are quite important, their absence does not mean that the patient does not have marked moderate or severe hyperkalemia. In fact, some people with quite severe hyperkalemia have no ECG changes. It seems, for reasons that are a little bit unclear, that people who are older and people who are diabetic don't tend to have the ECG changes that we typically describe. And the same thing can be said of patients on dialysis. They don't tend to have the classic ECG changes. So the risk is present, but the ECG isn't quite as sensitive to the changes. So really important and characteristic ECG changes that are not sensitive but pretty specific.
So how should hyperkalemia be diagnosed in patients with chronic kidney disease?
Well, the diagnosis is actually pretty straightforward with routine blood work. It thankfully is on a routine chemistry panel. Probably more important than how it should be diagnosed is the awareness that it should be looked for. Patients with CKD or heart failure or diabetes should be regularly evaluated with a renal panel to look to see whether they have any abnormalities in potassium. And this is absolutely the case with any change in dose or the initiation of medicines that might affect the RAAS system that we described before. Believe it or not, very simple things like taking a nonsteroidal anti-inflammatory medicine might in fact tip someone with CKD or tip someone with heart failure or diabetes into hyperkalemia, and patients have to be warned about these very common medications over the counter that can result in hyperkalemia and potentially important clinical problems. And so I tell all of our patients who are at risk, and that includes almost anyone with chronic kidney disease or almost anyone on one of these medicines, that they should avoid nonsteroidal anti-inflammatories. And if they develop any symptoms of muscle weakness or muscle tremors or these characteristic findings we talked about just before about that would indicate neuromuscular irritability, then they need to contact us right away or get to urgent care so we can check their potassium.
And do we have any concluding thoughts on this, Dr. Block?
Yeah, I guess my concluding thought would be we are, believe it or not, potassium may seem like something that is sort of well known and we sort of know everything we need to know, and that's absolutely not the case. And I think many of us in the field are really excited about some things being developed right now. As you probably are aware, there's a new trial with medicine that seems to be quite helpful for people with congestive heart failure that seems to save lives. It's a combination pill, but it includes a medicine called valsartan, which is likely to cause, it's a angiotensin receptor blocker, and it will increase potassium. And the point of that is that we have new therapies that are almost certainly going to prolong life and improve morbidity, but place patients at risk of high potassium. And we finally have several new products coming out. One's already approved, one's expected to be approved later this year, that are going to help us deal with the potassium in these patients and allow us to keep people on these life-saving medicines or organ-saving medicines. So it's actually an exciting time to be involved in the potassium field.
Thank you so much for spending some time with us today.
Oh, you're very welcome. I'm happy to do it.